The NEON study is a randomized controlled trial assessing the efficacy of microsurgical nerve repair in the digit and looking at the clinical benefit and cost effectiveness over no nerve repair. The short running title is Digital Nerve Suture or Not. My name's Dominic Power. I'm a hand and peripheral nerve surgeon. I work in the Birmingham Hand Centre and in the West Midlands Brachial Plexus and Peripheral Nerve Injury Service, and I'm a co-applicant on the NEON study. I have a declaration, and that's as a peripheral nerve surgeon, I'm a firm advocate of peripheral nerve repair. However, I recognise that sometimes a poorly performed repair can have adverse consequences for my patients. The evidence for much of what I do is based on the published literature, and many of the studies that are reported have design flaws, poor methodology, and repeat the same systematic error in outcomes reporting. I believe the NEON study is an amazing opportunity to set up collaborative research around the UK and contribute to the evidence base in hand and peripheral nerve surgery. The NIHR is one of the sources for funding of clinical research within the NHS, and the HTA programme initiates themed calls. Internally, evidence for given interventions is reviewed. There's consultation with experts within the field before defining the research question. The call in April 2018 was for a randomised controlled trial in digital nerve repair. For most interventions to be tested through the HTA programme, they should have been in use within the NHS, but there should be a limited evidence base around their use. A patient with an unexplored digital nerve injury may later present with a painful neuroma. Is this justification for early exploration of the wound? Well, I like to think that a careful repair of the nerve can minimise the risk of a neuroma. It allows me to maintain my microsurgical skills. It allows me to train my juniors in microneural repair. But does it result in increased functional benefit for the patients? A poorly performed nerve repair, one under tension, poor attention to suture placement, or under debridement, can result in a neuroma, and this can be extremely painful and debilitating for patients. Do we really know the results of our nerve repairs? Do we follow up our patients for long enough to understand the outcome from the peripheral nerve injury from their perspective? So does repairing a digital nerve prevent a neuroma? Chow published in 1993 with 72 single digital nerve repairs followed for a period of 2 years and 36 single digital nerves left unrepaired for the same period. There were 2 neuromas, equating to a 5.6% rate of neuroma in the unrepaired digital nerves. And there was a 36% dropout rate in the study. And long-term follow-up studies can be very challenging in this group of patients. Rebecca Dunlop undertook a systematic review which was published in BMJ Open in 2019. 30 studies were included, but only 8 reported neuroma incidents. The pooled results demonstrated a 4.6% neuroma rate following digital nerve repair and a 5% neuroma rate in unrepaired digital nerves. Of note was the poor reporting of neuroma assessment and diagnosis across all of these studies. In 2019, Arnold and his colleagues reviewed 50 studies on neuroma management. None of these addressed the diagnostic criteria, and the authors came up with their own algorithm for diagnosis. And this is useful for future studies in order to standardise the process of neuroma diagnosis. During a period of consultation in the development of the NEON study, I hosted a Peripheral Nerve Research Network meeting in Birmingham, attended by 40 hand surgeons and therapists. This was an opportunity to determine if there was clinical equipoise regarding a question of digital nerve suture and a control arm where the nerve was left unsutured. In addition, I presented this clinical case where a patient had had a digital nerve repair, then had a suboptimal outcome with spontaneous and evoked pain, limitation of grip, and reduced diminished protective sensation in the repaired nerve territory. Of the 40 clinicians who were canvassed, only 1 elected to re-explore this nerve and undertake an excision and a graft. This perhaps explains how we feel about peripheral nerve surgery. Perhaps the best outcome is achieved at the first operation. There's uncertainty regarding the outcome of revision surgery, certainly uncertainty regarding the diagnosis, and there are challenges in managing the neuropathic pain patient. But it rather surprised me And perhaps on reflection, I realise that many of our patients aren't followed up in the long term. And do we really know the clinical outcome for our patients following nerve repair in the hand? An earlier systematic review was published in 2013 and reported on more than 1,300 end-to-end digital nerve repairs followed up for 12 months with 2-point discrimination outcome measurements. Static 2-point discrimination is the standard, although the moving 2-point discrimination described by Dellen can also be incorporated in the Hyatt classification. The Hyatt classification ranks the repair, with S4 being deemed excellent when there is 6 mm or less static 2-point discrimination recovery. When the pooled results are tabulated for end-to-end nerve coaptation at the digital nerve level, 28% of patients achieved S4 level and 78% S3 or greater outcome. Of note, 21% of patients were deemed a poor outcome or had a failure of repair. In the later systematic review, 19 of 30 studies reported 2-point discrimination and the results could be pooled for analysis. 10 of these studies included children, and so the results must be interpreted cautiously. A higher threshold of classification, Hyatt S4, excellent level, was used for determining outcome, and 24% of all digital nerves achieved this level, and the range reported was 8 to 60 across the 19 studies. What is the level of sensory recovery without repair of a digital nerve? Well, in Chow's paper from 1993, the 2-point discrimination findings were documented for the 36 single digital nerves followed up for the 2-year period. Interval follow-up assessment of these patients allows understanding of the improvement that occurs in terms of S3 plus and S4 sensation over time. 31% of patients following a digital nerve repair were ranked as good or excellent at 12 months, and this reached 90% at 24 months. This is unlikely due to neural regeneration and more likely due to neural plasticity and the learning phenomena that's associated with repetition of the 2-point discrimination test and improvements in quality of feeling after digital nerve repair. The results, however, must be interpreted with caution, and it does mean that the follow-up time period for any future study looking at digital nerve repair is important. Of note, in the unrepaired digital nerves, only 6% of patients achieved S3 plus and S4 during the study period. However, of interest is 27% of patients who did not have repair of their digital nerve achieved protective sensation or better. Is this due to cross-innovation, so that the adjacent digital nerve territory has some overlap which is recruited, or is it actually due to collateral sprouting from the intact adjacent digital nerve into the denervated area of skin? Studies purporting to report sensory outcome as measured by 2-point discrimination should be interpreted with caution. 2-point discrimination remains a poor outcome measure, with variations in performance between studies, little inter- and intra-observer reliability, and a learning phenomena, such that without further neural regeneration, functional measurements can improve over time. An attempt at trying to determine whether cross-innovation from an intact digital nerve in the same digit can provide some route for sensory recovery after digital nerve injury was made in this paper published in 2016. The authors compared the results of nerve repair measured by 2-point discrimination in 28 digits, 18 where a single digital nerve had been injured and repaired, and 10 where both digital nerves had been injured and repaired, and they demonstrated that there was no difference between the two groups. I think the results should be interpreted with caution, and it may be that some form of collateral sprouting does play a role in a digit where there is no recovery through the original nerve injury site. However, further work needs to be done to determine this. Professor Jerish-Herold is a co-applicant on the NEON study. She presented in 2005 the results of a systematic review looking for evidence of validity, reliability and responsiveness of tests of sensory measurement. The results concluded that touch threshold testing with Weinstein enhanced sensory test and tactile gnosis using the shape texture identification were superior measures of performance compared to 2-point discrimination. But what about a patient-reported outcome following digital nerve repair? In the study by Dunlop in 2019, 3 of 30 studies used the DASH score, which isn't validated in digital nerve injury, and 8 studies reported patient opinion of treatment using 8 distinct different methods. There's a lack of consensus when it comes to patient-reported outcomes in hand surgery and also in nerve surgery, and some work needs to be done in this area to provide more meaningful interpretation of the results of any interventions. So what's the ideal design for a study looking at digital nerve repair? We're rather constrained by the research funding into performing a randomized controlled trial. But of course, our real-world evidence from large-scale data captured can be quite powerful. And sometimes a randomized controlled trial with too many inclusion and exclusion criteria can be so sanitized that the results may not necessarily be transferable to our real-world population. This bronze represents Themis, the Greek goddess of justice, more commonly seen around legal establishments in various incarnations representing the legal process. It's a very good representation of evidence-based medicine using the randomized controlled trial. The book under the right foot represents the book of knowledge, so this is the existing evidence base which is largely ignored. It can help shape or frame a question, but when comparing the outcome of a particular study, just the evidence from the two arms is presented. And this is why the scales do not have a foundation, but are measured against each other. The blindfolding is supposed to represent impartiality in law, so that justice can be achieved irrespective of status and wealth. But in research, it will be the blinding of either the observer, the patient, or both. The serpent at the feet represents evil, and in research terms, perhaps our inherent conscious and unconscious biases. And the sword, well, that's supposed to represent swift and decisive justice or retribution. In research, it may represent contention, conflict arising from our preconceptions, or maybe it's just symbolic of a scalpel representing surgical research. Whatever the meaning, a healthy debate based on a robust review of the book of knowledge and taking steps to recognise and understand our preconceptions and prejudices is key to producing new evidence that is capable of influencing future practice. Research into the outcomes after peripheral nerve injury was a key objective of the priority setting partnership between the BSSH and the James Lind Alliance. Development and delivery of a trial of this scale is a lengthy process and a challenging one. It'll be some time before the data is available and can be weighed and a final outcome can be reached. The process has started several years ago with a review of the literature, publication of a systematic review, and then shaping and framing a relevant and important research question by consultation with clinicians and with patients. The developed protocol was submitted for approvals both through the Research Ethics Committee and the Health Research Authority, and recruitment has commenced at a number of sites. Like with most studies of this size, an in-study pilot is an essential part of the study design and delivery. This enables any initial problems to be ironed out, look at recruitment criteria, and ensure that there are no issues with blinding. All trials of this scale are subject to external review with the Data Monitoring and Ethics Committee, and further trial rollout will be contingent on adequate recruitment and retention of patients within the study. The next few slides will focus on the NEON trial design. If you'd like further information or would like to get involved either during this pilot phase or within the wider recruitment, then there'll be some further instruction in the subsequent talk and an opportunity after the panel discussion. The trial is a pragmatic, multi-centre, patient and assessor-blinded randomised controlled trial into digital nerve repair. Patients with a complete digital nerve laceration in any single digit can be enrolled. The intervention is a microsurgical suture and the control arm is realignment of the nerve ends but without sutures. The outcome will be the eye-hand questionnaire patient-reported outcome measure as the primary outcome measure, and 478 patients will be recruited across the NHS with an estimated 9-month internal pilot phase. The inclusion and exclusion criteria for the NEON study are listed here. Adult patients over the age of 18 with the laceration and a suspected single digital nerve injury in a digit can be included in the study. There are a number of exclusion criteria. If the injury is more than 10 days old, it's likely that it cannot be repaired primarily, and so these patients are excluded. In addition, if there's any significant nerve gap that would preclude a tension-free repair, these patients are excluded. If there's an injury to both nerves in the same digit, or if there is an injury outside the target zone. The two arms of the study are the intervention arm, where after wound expiration and confirmation of eligibility, the patient will have the digital nerve sutured using end-to-end epidural sutures, and the control arm, where after washout and confirmation of eligibility, the nerve ends will be realigned and laid back in situ, but there will be no microsurgical repair. Patients and the assessors will not know which arm the patient has been allocated to. The primary objective of this study is to ascertain the clinical effectiveness of microsurgical nerve repair for patients with digital nerve injuries, and the outcome measure used will be the eye-hand questionnaire, which is a 32-item patient-reported outcome measure specifically developed for evaluation of outcome after nerve problems within the hand. The secondary objectives of the study are further assessment of the neurosensory and functional recovery between the two surgical arms, evaluating the cost effectiveness of surgical repair of the nerve, and then looking at the complications of surgery and any differences in neuroma rates between the two arms. For this, the outcome measures used will be the PEM score, the EQ5D, and health resource use in terms of costing. The clinical assessments will use the West monofilaments, 2-point discrimination using the discriminator wheel, and the STI tool for measuring shape, texture, and identification. Review of medical records will ascertain any complications, any reoperation, and any extended periods of rehabilitation that were necessary. The clinical assessments will involve touch thresholds using the Weinstein Enhanced Sensory Test, or West monofilaments. There'll be static 2-point discrimination assessed using a discriminator wheel, and tactile gnosis using the shape texture identification test tool. In addition, neuroma and cold intolerance will be evaluated. During the screening and randomization phase, the initial contact with the patient will be dependent on the local working arrangements, but typically this will be the first contact with the specialist hand team. This is an opportunity to provide a patient information sheet in a patient who may have clinical eligibility. On the day of surgery, formal consent is obtained, and if the patient has confirmation of eligibility in theatre, then the nerve can be randomized to either the intervention arm for repair with microsurgical sutures, or realignment and wound washout and debridement enclosure only. There are a number of follow-up intervals, and at 6 weeks, 3 months, 6 months and 12 months the main clinical assessments and patient questionnaires will be undertaken. There will be an opportunity for further data capture points up to 24 months, particularly using hospital episode statistic information regarding readmission and reoperation. The NEON study is up and running. It opened its first site in September 2020. It's still in the pilot phase, and so far 5 sites have been opened and 49 patients are screened with 10 recruited patients. Following this talk, there'll be a short explanation of what to do if you or your unit would like to get involved, and there'll be a panel discussion, but we hope you'll be able to join us on this journey and engage in this multi-centre trial in peripheral nerve surgery. The main focus of the NEON study is to examine the effects of digital nerve repair on patient function and outcome, and also the cost effectiveness of this intervention. But there are numerous added benefits of being involved in a study of this size and this magnitude. It will allow us to establish multi-centre collaboration in hand and nerve surgery. We hope that we'll be able to standardise the diagnosis of neuroma after nerve repair, determine the true neuroma rate following repair and non-repaired digital nerves, and determine relevant patient-reported outcomes after nerve surgery in the hand. We will have some ability to compare our outcomes to some of the historic papers that have been written in this area due to the breadth of secondary outcome measures that have been used. But we're focusing on using validated sensory assessment tools. The hope is that there'll be some further development of research capabilities across the breadth of hand surgery in the UK, and that the outcome data from this study will help inform the development of future trials looking at improving the quality and outcome after peripheral nerve repair. Thank you for your time.